Great. Well, thank you, George. Thank the program directors. It's an honor to be here. I'm going to be briefly speaking about DAPT after coronary revascularization, giving you an update on where we've come from, where we are, where we're going, the current guidelines, and a couple future perspectives that I'll give for you. As George mentioned, I've been very involved with the guidelines for the last several decades. I have no financial relationships. So let's just take a minute reminding ourselves of where we've come from. So it was back in 1995 that Antonio Colombo first invented the concept of using DAPT instead of anticoagulation, and 4 weeks of therapy were validated in numerous studies. In the early 2000s, we had our first generation stents, and we treated people with DAPT for 3 to 6 months, and that was based on the study protocols. In the mid-2000s, this concern about delayed endothelialization emerged. The basket late was presented at ACC, much to the chagrin of many people. With late stent thrombosis, increased MI. This led to an FDA panel and subsequent recommendations that patients should be treated for 12 months with DAPT. In the mid to late 2000s, we had the second generation stents. As you all know, these are better and clearly much less thrombogenic. Around the same time, though, there were emerging and increasing concerns about bleeding, and this emerged from bivalirudin trials and a lot of publications from the CRF group, as well as longer-term concerns about bleeding by Sunil Rao and the Duke group. This led then to many trials of looking at shorter duration DAPT, but at the same time, paradoxically, there were also longer duration DAPT trials trying to look at very late stent thrombosis and decreased MI. So let's start off there. This is a slide Roxana gave to me years ago, which I love. It summarizes the contemporary trials, and you can divide these into short versus standard duration trials, short versus long trials, and standard versus long duration trials. When we did our 2016 DAPT guidelines, of which Roxana was a member, we had our evidence review committee look at all these studies and summarize them. And I'm going to show you the results in 2 slides. So let's first look at studies of prolonged versus standard duration DAPT. And what was found is prolonged DAPT decreases stent thrombosis, decreases MI, as you'd expect, increases bleeding, no difference in mortality. Importantly, taken as a whole, these studies, though, of prolonged DAPT, an additional 18 to 36 months, lead to numerically about a 1 to 2% absolute decrease in thrombotic events at the cost of about a 1% increase in bleeding. If you look at the shorter versus standard duration trials, what we see is with shorter duration DAPT, no difference in stent thrombosis or MI, borderline significant decrease in bleeding. The key caveat, though, when you look at these trials, is these were predominantly low-risk patients with stable CAD, generally enrolled in studies that were underpowered to detect differences in stent thrombosis. The other big trial was Pegasus. These are in post-MI patients, and you'll note that the majority of patients were stented. The study did lead to a highly statistically significant reduction in ischemic events, but if you look at it a little bit more closely, you'll find in general that there was about a 1.5% decrease in ischemia, almost equally balanced with a 1.5% increase in bleeding, and that the numbers needed to treat are about the numbers needed to harm in terms of bleeding events. This is not to say that we should not treat many patients with prolonged DAPT, but more so that we just need to more carefully select which patients are most likely to benefit. So we took all these studies in 2016. We issued our DAPT guidelines. I'll summarize them for you briefly. For stable disease, we decreased standard duration to 6 months, but more importantly, gave you the option of shorter duration, perhaps 3 months, in those at high bleeding risk, as well as a 2B option for longer duration DAPT. For acute coronary syndrome, we stuck with a 12-month standard duration, but again, importantly, gave practitioners the option for shorter duration, perhaps 6 months in ACS patients, along with, again, a Class 2B recommendation for potentially longer duration DAPT. Also importantly, we emphasized that you should individualize care, and you had the option of treating people with either standard, short, or longer duration DAPT based on the patient's benefit and risk ratio. I was privileged to serve with the Europeans when they in the next year did their DAPT guidelines. They are remarkably similar to ours, which is good. That means there was nice concordance among the groups in interpreting the data. Again, 6 months ADAPT for stable disease, 12 months ADAPT for ACS as standard therapy. Class 2 recommendations for shorter duration and high bleeding risk patients, 1 to 3 months for stable patients, 6 months for ACS patients, and just like us, they ultimately settled upon a Class 2B recommendation for prolonged DAPT. So where are we on our DAPT evolution at this time? Well, for the first time, we see a split with different recommendations for patients with stable disease versus those with acute coronary syndromes. And really, for the first time, a very strong emphasis on individualizing care based on ischemia and bleeding risk. Now, one not very well-known trial, but a critically important trial that came out right after our guidelines is Smartdate. This is probably the most contemporaneous trial that we have of DAPT. 2,700 patients with ACS undergoing stenting with all new generation drug-eluting stents. Patients randomized to just 6 months ADAPT to see if shorter duration was better or okay, versus 12 months, and the 12-month group was actually treated for about 18 months. Now, the study did meet its non-inferiority endpoint as far as 6 months ADAPT, but to the investigators' credit, they investigated this a little bit more. When they did landmark analysis, they noticed the curves were diverging at 6 months, and they really pinned this down on increasing MI with just 6 months of therapy. And again, to their credit, even though their study met its non-inferiority criteria, they concluded that based on their results and the increased risk of MI with just 6 months ADAPT, that the guideline should stay as 12 months for standard therapy. 2 years ago, Eric Bates and I published this editorial emphasizing we really need to individualize patient care, and we noted that the estimated risk of future MI can vary 5 to 8-fold between low and high ischemic risk patients, and the bleeding risk can vary 4-fold between low and high bleeding risk patients. So again, we shouldn't treat all patients the same. Well, how do we risk stratify and decide who to treat short and long? This is what I call our master table of factors that increase ischemic and bleeding risks. And you can divide these into 3 things: patient characteristics, clinical characteristics, and procedural factors. If you want to use a risk score, you can use the DAPT score, you can use Roxana's Paris registry, or you can use what the Europeans do, the precise DAPT. All of these have about moderate predictive value. I want to, though, in the next 2 slides, give you my synthesis of all these scores and all the data that we have, how to weigh ischemic and bleeding risk. So there are 4 things that I look at for ischemic risk: history of coronary plaque rupture and acute coronary syndromes. As Deepak Baucus pointed out, that the people who are most likely to have plaque rupture in the future are those who have had plaque rupture in the past. And in fact, this is the greatest predictor of who is going to have a future MI. And related to this, when you treat people with prolonged DAPT, more than 12 months, the majority of benefit is not in preventing very late stent thrombosis, but in preventing future spontaneous MI. The second factor is patient complexity or their risk factors, and there's 4 things in particular to pay aware of. Do they have diabetes, CKD, are they still smoking, or do they have what I call extensive CAD, including prior revascularization? The hazard ratio for all of these are 1.5 to 2. We also learned from an excellent publication in JACC several years ago that we should look at procedural complexity. Patients who have what are termed a complex PCI in this analysis did worse if they were treated with a shorter duration ADAPT, only 3 to 6 months, versus if they were treated with at least 12 months ADAPT. And then the 4th thing I look at that can't be accounted for in any risk factor is the myocardial territory at risk, because obviously the consequences are much more dire if someone clots off a proximal LAD stent than if they happen to clot off a small OM stent. The 5 major bleeding risk factors I would emphasize to you are the most important to think about: advanced age, anemia, CKD, prior bleeding, and concomitant oral anticoagulant use. Now, an interesting trend in some of the more recent trials is even shorter DAPT. If you look at these trials, in general, just 1 to 3 months of DAPT, and then antiplatelet monotherapy. And another interesting trend is the use of antiplatelet monotherapy being with a P2Y12 inhibitor instead of continuing the aspirin. So as we look further into our DAPT evolution, we see at least some studies and some clinical practice moving to at least some patients to very short DAPT, 1 to 3 months. I think for ACS, based on Smartdate, 12 months will probably continue. But we also see the emergence of this third treatment arm, P2Y12 monotherapy. Now, I'm not going to go into detail about the combination therapy trials. I'll just briefly mention the latest trial, Augustus, which I think is an excellent trial. As many of you already know, when you treat patients with just double therapy and leave out the aspirin, much less bleeding than with triple therapy. And in this study, when you looked at death or hospitalization, no difference with double therapy versus triple therapy, though if you read the manuscript carefully, there were numerically higher incidents of MI and stent thrombosis, actually almost twice the stent thrombosis in the group treated without aspirin. So what are the best guidelines to look at for combination therapy? The Europeans have excellent guidelines. These were formulated before Redual and Augustus. In general, they recommended 1 to 6 months of triple therapy, but in patients where you're more concerned about bleeding, a class 2A recommendation to just go right to double therapy. There's also an excellent North American perspective published a year ago in Circulation. In this publication, even before Augustus, they suggest as the default strategy, double therapy. And in patients at high ischemic risk, just 1 month of triple therapy before switching to double therapy. And in patients at high bleeding but low ischemic risk, going right to double therapy and only doing that for 6 months before stopping all your antiplatelet therapy. So what are my conclusions and predictions for the DAPT-related guidelines and clinical practice? I think there's going to be a further emphasis on the individualization of DAPT duration based on the patient's ischemic and bleeding risk. I hope and think there should be an integration of this concept of PCI complexity and probably also myocardial territory at risk into future DAPT duration recommendations, and certainly we should include this in our clinical practice. DAPT for stable disease, at least some low-risk PCI and high-risk bleeding patients, given how good these stents are currently, may move to just 1 to 3 months. Again, I think standard duration of DAPT for ACS, based on Smartdate, should and will remain at 12 months. And then double therapy, or just very short triple therapy, 1 month of therapy, really I think should become the dominant strategy and the dominant strategy in the next round of guidelines. Double therapy for high bleeding risk patients or non-high thrombotic risk patients, such as a non-complex PCI or not a large territory at risk. And then just 1 month of triple therapy for the non-very high bleeding risk patients who are at high thrombotic risk. Again, those undergoing complex PCI or large myocardial territory at risk. And then finally, this increasing move to P2Y12 monotherapy. I think we're already there when we go from triple therapy directly to double therapy. I think we'll await Roxana's Twilight study to look at how to treat people who are not on OAT. And we'll hear more of this in the subsequent talks as Roxana and Deepak go at it. Thank you very much.